causes stuffy nose, congestion. So congestion, think about that. A little simpler than these, right?
Yeah.
But they can impact your respiratory system nonetheless. Congestion, what else were you talking about? Coughing. Now you may not think about coughing as part of the respiratory system, but it really is. Why do you think it is?
Because it gets in to get rid of the mucus.
Things around.
Trying to get rid of mucus, protect the lungs. Exactly. Think about if you drink water wrong, and you're like, right? That's your body protecting the respiratory system. You get stuff that go into the respiratory system, just environmental contaminants, smoke. Think about smoke right now, wildfires. In our state, because I'm writing a little thing for the New Mexico Nurse Association about it, New Mexico right now has 517,000 acres that have been burned, which is a lot. With wildfire smoke, you have really small particulate matter that you breathe in. That gets deeper into your lungs and bigger things because of the coughing, because of the mucus, because of that cilia you guys are talking about. That's to help get that out. Unfortunately, with wildfire smoke, it gets further down into the lungs because it's so small. It gets past those main defense mechanisms, gets embedded in the mucus, right? Gets embedded in places that it shouldn't be, and then your body kicks off the process to try and get it out, which is an immune response, which we've talked about, right? Inflammation, histamine. We've talked about histamine, right? Mast cells, they're all part of the immune system. These are pro-inflammatory things going on. So when these things kick off, inflammation kicks off. You have permeability in vascular system. You have mucus thickening because your body's like, hey, we've got an allergen in our nose. We're going to send out these histamines, create that histamine response. You're going to have a bunch of junk in your nose that you're constantly blowing out, right? Your eyes start watering a lot because you get stuff in your eyes. That's not related to respiratory, but allergens it is. So you get that watery eyes. Your eyes are trying to get rid of the allergen, or it could be something else. So histamines, think about some of the drugs we give for that.
Benadryl.
Right. Benadryl is one of them. Those are called antihistamines. Right, that's one of the drugs we give. Right. Those are our antihistamines. We are tricking the body. Again, we're trying to fiddle with the body. We're saying, hey, don't do that allergy response because it's inconvenient. Right? We don't like watery eyes. We don't like the nose. We don't like all of that stuff happening. So we'll take antihistamine, and it stops that right here. Now you have, and we'll talk about this in a minute, you have histamine receptors, lots of different places. The gut is another place you have histamine receptors. So when we talk about like the H2 antagonist, right? That's a histamine blocker for your stomach. That's to keep acid from being produced. So we use these, we use the antihistamines for a few different things. Nausea and vomiting, right? Motion sickness, scopolamine, things like that. Those are H1 antagonists. So they work on histamine receptors in the brain. Benadryl. Benadryl is also good, believe it or not, for making you sleepy. It's a sedative, as is a lot of those first generation antagonists. But it also helps with motion sickness. It's a happy side effect. You get to feel sleepy time, helps with motion sickness, helps with allergies. Mast cells was TNF. You remember what TNF alpha was? Think back to our rheumatoid arthritis discussion. Huh?
Tissue necrosis factor?
Yeah, that's another one of the pro-inflammatory mediators, if you will, that kick off inflammation, that kick off a lot of these things that happen when you have infection, when you have allergies, when you have these foreign bodies that you're breathing in. So when we come back, we'll take a break here in a little bit, but when we come back, I'll show you a picture of, I need to find that, a picture with a patient that has COVID. So, have you guys, or it doesn't have to be COVID, it could be heart, it could be surgery, something like that. Have you guys ever seen the lungs of somebody that's,
Yeah.
they're completely white, right? That's fluid that's in there. That's impacting that. It's impacting everything, right? And that's how they typically die. They just suffocate in their own fluids. So allergens, we got that. Colds. A lot of times if we have a common cold, right? That's a virus. It's in your respiratory tract. Your body starts fighting it. So you see a lot of these things start kicking off. And then you start to see the other effects that happen as your body tries to fight that. We're trying to manipulate, and we're saying, okay, if you have a common cold, you gotta write it out, mostly, right? It's a virus, but we can make it so it's a little more comfortable. You know, we can take a decongestant, right? We'll talk about those, decongestant. We can take a decongestant to help us breathe better. Decongestants, antihistamines, anything else. We have antitussives. We're going to talk about antitussives. What are those? Cough suppressants. Exactly.
Like codeine?
That is one. There is a drug that has codeine in it that
It's like
helps.
Chertosin, right?
Yeah, yeah. So that's one of them. So coughing. Eucalyptic. What is eucalyptic? Huh?
That's an expert.
Well, Mucinex, guaifenesin, great. But mucolytics, they loosen mucus, right? Because if you have really thick mucus.
That's an expert, right?
Guaifenesin?
No, the mucolytic.
Oh, yeah. Yeah, like guaifenesin or
Oh.
what's the trade name for that? Mucinex.
Huh?
Mucinex. You'll use those because a lot of times if you have a really thick mucus, so hydration status is a big piece with lots of mucus. Because with that mucus, how many of you guys have dealt with a trach that has really thick, nasty mucus in it? They are nasty, and I feel really bad, and they're getting clogged all the time, so you're pulling out these like mucus plugs. And part of that is, a lot of times your patients in the hospital are dehydrated, right? So that mucus, because they're dehydrated, gets sticky. And so, one of the things that happens, even if you have a cold, if you have allergies or something, you have that really thick mucus, it sits on stretch receptors in your respiratory tract. It triggers you to cough. And so one of the reasons you're coughing is because you have a bunch of discharge going down into your throat or into your throat. And it causes you to cough. And so sometimes we can loosen that up to help with the cough because it gets it off those receptors.
That's why whenever patients call, like for pediatric patients, we don't want to turn off the cough, we want to let it keep going.
If it's productive. Yeah. Productive coughs, you don't want to give an
Cough
antitussive.
medicine.
Yeah, you want them to cough because, and that's something we'll talk about, if it's productive, we'll use something like, you know, an expectorant or something else, mucolytic, that's going to loosen those secretions just to help with it. But if it's a very productive cough, and they're just coughing up junk, let it go. You want it to go because that's part of your body getting rid of that crap that's in your body. So you won't give antitussives to people with productive coughs, right? If it's a dry, irritating cough where nothing's coming out, that's when you give an antitussive. So you can stop that.
What classes are benzonazine?
Is it a tate? Yeah, I know what you're talking about. Yeah, I don't know. I call it that
Like
because
pneumonia
it
and stuff.
makes me think of a respiratory. Now, we're not going to get through all of this today, obviously, because we have a test. But, we'll get
I
through
think
it.
of like fluid overload when patients are in congested heart failure, it affects their pulmonary.
Yeah, because where does fluid go to the lowest spot, right? So, oops. So it'll go into your lungs, and with men, it'll go into their scrotal sac. I don't know if you guys have seen men that are really badly overloaded, fluid overloaded. I'm not kidding you. It'll be the size of somebody's head, and you're just like, mother of God. And so,
Sometimes too, when like you place them in an awful position, everything retains there, like.
yeah,
if
yeah,
you
because it's a
topple their
low
bed,
spot. It's a low spot.
They get
Yeah.
allergized.
What?
I was finding that you made a little ball hammock for them.
Yeah,
with
you
the-
use a
A
pillowcase.
pillowcase.
Yeah, and you kind of lift it up. But think about that when you're turning them. You know, if you're turning them and you've got this giant ball of fluid, it hurts a lot.
Yeah, there was a guy who with like a pressure ulcer on the bottom of one from the nursing home, and it's so sad. It
Yeah.
hurts them a lot.
Yeah, it's from fluid. Well, just fluid overload in general, yeah.
Or
So-
like if you place them in like a position, it's not going
Yeah. So you'll find places that get fluid, low places. That's one of them. All right, so let's see here. Okay, so common cold. Let's look at the common cold. We already talked about this a little bit. This is where you get an infection. The most common one is rhinovirus or influenza virus. These invade those upper airway tissues. When that happens, your body kicks off, right? Kicks off that histamine response, the mast cells, white blood cells. All that stuff happens. You increase that mucus production to get that virus out. Kind of, you know, think of fly paper. Fly paper. Have you ever seen fly paper? Where flies will stick to it. So it's kind of like that. The viruses get stuck in that mucus, and then you get rid of it. Right? This is very common. This is one of the very common reasons we give decongestants, we give antihistamines. It's really to help with that uncomfortableness, right? Right here, we were just talking about that. Fluid's going to drip down because you've got excessive fluid being produced. Drips down into your upper respiratory tract, into your stomach. So you have a lot of patients that they feel nauseous just because all that draining. They have a sore throat.
And if you look in with the light, you can see the nasal drip from the back.
Yeah.
Have you looked at that?
I have not looked at that.
One time one of the providers showed me on the kit.
Yeah.
If you open up their mouth, you can see the closed nasal drip going back.
Yeah. And that post-nasal drip causes redness, causes sore throat, causes you to yell. Right? I don't know if you've ever thrown up a bunch of mucus. That's because you probably have a cold and you've just been kind of swallowing it, right? Because you use a lot of swallowing on stuff. So, think about all that with your poor patients, or if you're in that situation, right? Still part of the common cold stuff. This whole part right here is what I was talking about. When you have the histamine response happen, that inflammatory response start to happen because of the TNF alpha, because of histamines, leukotrienes, things like that. All those pieces that are part of the immune system, they need to get to where that infection is, or they need to get somewhere, right? That's why your vessels open up. And when you hear about patients that are in SIRS or ARDS or something like that, one of the biggest issues is blood pressure. You have a hell of a time managing blood pressure, and you have a hell of a time managing fluid balance. Because when your vessels open up to let all the bigger stuff out into the tissues to go fight whatever it is they're fighting, that fluid gets out of the vessels, right? Inside the vessels, that's what goes to your heart. Heart plays into blood pressure. It's all opened up and it's going elsewhere. Drops your blood pressure, right? And it puts fluid where it shouldn't be. So you start to see a lot of pitting edema. You start to see, I mean, if you see a person that's really fluid overloaded, they'll be weeping. Their skin is tight and they're weeping. They have so much fluid where it's not supposed to be. It's just, right? It's because, a lot of times it's because of this response right here. The histamines, all those pro-inflammatory molecules that in the body. But it's really hard to deal with blood pressure and fluid, because one of the easy fixes for low blood pressure is what? Fluids. Exactly. Easy fix. You can go grab a bag of saline, right? Start infusing fluid in there. However, with these patients, you're just kind of feeding a fire because they're still open. That's why you give a bunch of pressors to try to close them up a little bit, try to tighten up those vessels, and then give them some fluid. But it's a hard balance, and it's a tricky balance. Now, we're talking about the common cold here. So, what I'm talking about is if you have a systemic infection, like COVID or pneumonia or anything like that, that can take over your body, that's when it gets really dangerous. Common cold, we're gonna manage like a cold, right? Write it out, take your decongestants, things like that. We'll talk a little bit more about examples of that here in just a minute. Let's see, treatment. Again, treatment of your cold, it's all symptomatic, right? It's a virus. You don't have a magic pill really to get rid of the virus. There are antivirals out there, but typically for a cold, you kind of ride it out. And you're gonna manage symptoms, right? You're gonna manage the congestion, tired feeling, all that. You're gonna get rest, drink lots of fluids, that stuff. That. So one of the things to think about when you're talking about your pediatric population is cough medicines, right? Cough medicines, be careful with your younger children population. It impacts them quite a bit, especially the over-the-counter ones. And look at that little part down here. They've done research on it. It doesn't really matter. It doesn't help, right? It's really just for convenience, but it's not great for your kids. So keep that in mind when you have kids as patients or your own, right? And you're giving cough medicine. So antihistamines, we talked about that, right? Let me see. I've got a better. Here we go. So if you look here, histamine is one of those inflammatory mediators that we just talked about. Mast cells involved with that, right? We'll put that up here. That's where your TNF alpha also is part of that mast cell piece. But you have H1, H2, H3 receptors, and you can see where they all belong. So when you're giving an antihistamine, you're going to be impacting all of them. Typically, we want to impact H1s because they're more peripheral, they're on the veins, arteries. That's how you get that help with those symptoms. Think of urticaria, or pruritus. You get hives, or you're starting to itch. Why is that happening?
Is it drawing everything up?
So, what do you mean drawing everything up?
Like drawing? Like
drawing.
What kind of issue?
So what's happening is your vessels are reacting, right? So that rash or those big hives, that's a vascular thing happening, and it's thing in your skin happening to an allergy, right? Or, so when you start impacting your H1s, it also will impact H1s in your brain. So drugs like Benadryl or diphenhydramine, one of the things that happens is sedation, right? Because it's a centrally acting drug, but it's also a peripherally acting drug. So remember, we talked about this. Anytime you're working with the brain and spinal cord, that's central, right? Everything else is peripheral. And so when we're talking about diphenhydramine or some of those first generation antihistamines, they work in the brain and they work out here peripherally as well. Okay? Anytime you're working in the central nervous system, sedation with your antihistamine, sedation happens. So that's one of the things you're going to talk to patients about, right? Sedation. You don't want to take antihistamines with alcohol or any other sedative because you're compounding that sedation, right? So, but you have your H2 receptors. Where's the stomach? There's the stomach. There, right? So when we talk GI, you're going to be messing with the H2 receptors in the stomach to reduce acid production. Another use for, what would be an antihistamine, basically. They call it something different. They call it an H2 antagonist. But then you have them in the gut, lungs. So these are where you have these histamine receptors, kind of all over, right? So anytime you're giving an antihistamine, you're impacting more than just what you're thinking, right? But it's that weighing it out, pros versus cons, right? You're taking an antihistamine because you're having an allergic reaction, you're having, mostly allergic reaction, or that histamine response, you're trying to tone it down, right? We're the master fiddlers, we're fiddling with this. We're saying, hey, we don't want the runny nose, we don't want the itching, we don't want the hives. We're gonna mess with it.
But antihistamines take 2 weeks to get into the body, right? Because they're going in, so it's 2 weeks.
No, they're faster than that. Yeah, your antihistamines are a lot faster than that. So you've got first generation antihistamines. So diphenhydramine, there's a list in here. Diphenhydramine, scopolamine, some of those types of medications, those are first generation. Any of your first generation antihistamines, they're centrally acting and peripherally acting, which means it'll cause sedation. And because it's centrally acting, it also helps with motion sickness. It also helps with nausea and vomiting because it works in a similar area. So the second, third generation antihistamines, you can probably guess why they decided to come up with them, right? Fewer side effects. You want to make sure that people can take Claritin or Loratadine daily and not be a zombie walking around. But you're trying to manage those histamine responses to allergens. Those second and third generation antihistamines are typically peripheral. So they typically just work peripherally, so you don't have the same issue with sedation. Now there's still, some sedation that can happen, but typically if it's your second and third generation antihistamines, they work peripherally, not as much centrally, so you don't have the sedation. And that's kind of a big difference on that. Let's think here, anything else on that? Any other thoughts on that? Antihistamines. So, what is one of the main properties of antihistamines? It mimics something else. What? Yes, your antihistamines will mimic anticholinergic responses, right? Because it dries you out, that kind of stuff. So when you're thinking of what's happening when you're giving an antihistamine, think about kind of what happens with an anticholinergic. Kind of dries you out, and some of the other things as well. But think, anticholinergic properties with your antihistamine, because that'll help when you look at questions. That'll help when you teach your patients, right? It depends on which one you're giving. What's angioedema? So we all know what anaphylaxis is, right?
It's inflammation of the, vessels?
Angioedema? Yes, but particularly where?
In the heart? No, in the
Huh?
veins? Arteries.
Face.
Veins.
So there are medications where angioedema can happen, and it's an emergency. You have a patient, it's kind of like an anaphylactic reaction, but it focuses on your face. Your tongue swells, you get the swelling in your face, and if that's happening, what is your concern? Airway, breathing, exactly. So angioedema is something that certain medications, that's one of the side effects, that's one of the adverse effects that you need to look out for, is the angioedema. And it's swelling of the face and tongue. So it impacts your airway. Anytime anything impacts your airway, pay attention to it, right? Because it does not take long for your patient to freak out and then pass out, and then you're intubating them, and it's a problem, right? So angioedema is one of the things that is mediated by histamines. Drug fevers, insect bite reactions.
So is that an indication of anaphylaxis as well, like a bee sting?
If you see angioedema, it could be, but you would probably see this happen more readily if you're allergic to that insect. Angioedema is more tied to drug interactions.
Oh, okay.
But airway is still a major concern. Insect bites, you'll get, how many of you guys are allergic to bees? Do you have an EpiPen? Are you, yeah. So bee stings, if you're allergic to them, they can be bad, right? You skip all the other stuff, you go right to anaphylaxis. What happens during anaphylaxis?
Your throat closes.
Your throat closes, exactly.
Happened to my son when he was 2, we didn't know he was allergic to peanuts.
Oh,
It was
That's
bad. His
yeah.
whole face swelled up like those goldfish that have the puffy eyes.
yep,
That's what he looked like.
yeah. Or sometimes if you give your younger kids amoxicillin, penicillin, something like that, you may not know that they're allergic to it yet. So that's one of those times where anaphylaxis can be. So you have closing of the airway, right? You have this histamine response basically through your entire body. So you won't have
Like if you give the
vasoconstriction.
pen, it'll constrict right there.
Well, if you give a pin, that's
Yeah.
different because you're putting in that,
To go to the
giving
emergency
them,
room.
epi. Right, but that's really for airway, because that epi triggers beta 2 receptors from the body. Yeah.
He had to be tested throughout the years.
For your peanut butter?
Or the peanut, yeah,
Or
all
the
that
peanut.
stuff.
Yeah,
Yeah, he grew out of it though,
Yeah.
thank God.
yeah, and they'll do tests to see there's a certain
Yeah,
level, but you have to do it at the doctor's office so they can watch you and make sure that you.
yeah, and then they
So
drew
it's-
all those things on his back, those.
Yeah.
So it's not a lifelong thing?
Can be for
It
some
can
people,
be.
it depends on the
Yeah.
person,
Okay.
yeah. But yeah, if it's an insect bite, like a bee sting, your body just goes right into that anaphylaxis mode, which the biggest concern is that closing of the airway, and because it's systemic, you're gonna have your blood pressure is gonna tank, because your body's just opening wide open, right? So that's why it's dangerous. That's why epi combats that. So for, anaphylaxis or allergic reactions, if it's bad, so if it's angioedema or if it's anaphylaxis, don't go try to get Benadryl to fix it, because Benadryl is an antihistamine. It will help with the rash. It will help with, blood pressure. It will help with secretions of that, but it will not do anything to your airway, right? It does not do anything for the airway. That's why if you're in anaphylaxis, you need to give them epi. You can give Benadryl for other stuff, but if they're having trouble breathing, Benadryl's not gonna help. It's just not gonna help. You need to have epi, because that's the bronchodilator, right? So, here we go. We just talked about this, anaphylaxis. This is a biggie, right?
Sorry, I don't know.
No, that's all right.
So you give epi for any one of these, not Benadryl?
No, you could give Benadryl for these for sure.
Okay.
You would give some, or allergic rhinitis for sure. But anaphylaxis and angioedema, you're gonna go right to epi.
Okay.
But you still can give Benadryl, or you can still give an antihistamine, or you could give a steroid or something like that after epi.
Okay.
So we'll talk about kind of the order of events you have at anaphylaxis. But these two you need to hit with epi first because it's impacting your airway. Antihistamines don't do anything for dilating your airway. So talk about that. So here's your anticholinergic, antihistaminic, and your sedatives. So here's here's some of the examples that we'll use. I'm trying to think. I brought this here. Let's see what ATI likes. Oh, let's see here. Diphenhydramine, that's your prototype drug, right? So you guys remember what prototype drug means? Means all the others are kind of modeled after it, right? So in terms of sedating or first generation, because diphenhydramine is a first generation antihistamine. That's your prototype drug. That's what ATI likes. And for non-sedating or your first or second generation antihistamine, ATI likes cetirizine, which is Zyrtec, but you have fexofenadine, you have loratadine. Those are also first or second, or not first, those are also second. I can't remember which one's third, but those are your later generations. Those work peripherally. These work peripherally. That one works centrally and peripherally. So you get your antihistaminic response. So your vasculature kind of tightens up. You have those anticholinergic effects so that you don't have all the secretions going out. And if it's centrally acting, you're going to have sedation. So that'll be something to think about. Let's see, we'll go past that. We already talked about it. Here's some of the things what happens when you give the antihistamines. I'm gonna walk over here so talk about it. So vasodilation, blockers prevents adverse consequences. So the adverse consequences are what are below that, right? We're trying to cause vasoconstriction, you're trying to decrease capillary permeability, that's why you're using those antihistamines. The thing about your antihistamines, like if you're taking them for seasonal allergies, for example, you kind of have to stay on top of it, right? And so you kind of have to build up your antihistamines. Otherwise, if you have a bunch of allergens on the receptors, we'll just talk about ferritin, for example. They're not strong enough to kick off the allergen, so you have to catch the open receptors so that the allergen cannot get on it first. So that's why they say take them, if you know juniper season is going to keep your butt, start taking them a little bit before, so you start building that up, you start blocking those receptors. If you, like me, wait till the last minute when you're a wreck and you're miserable, it takes a little bit.
So
You
it
gotta-
takes 2 weeks for them to start working, like up to 2 weeks.
Well, did you read that somewhere?
No, that's what I tell the patients. I'm like, make sure your kid takes their allergy medication for more than 2 weeks because then it starts working. It's not gonna work if you take it today and not take it for a week and then.
That is true, but be careful on the timeline, because I don't know if there's a timeline like 2 weeks. But it is true that they need to take it. It's true, though, that they need to take it a little bit. If you find it where it says 2 weeks, let me know. But the point is, make sure you start taking it beforehand. Or, give it a couple of days for it to start working, because you've got to get that antihistamine blocking action going. So if you tell them 2 weeks, that's probably good, because then they have a higher expectation and it starts working sooner. So then they're like, yeah, it worked. But that's one of the reasons why you should take it and continue taking it, because you need to keep making sure those receptors are blocked. Do you guys look at this
What
stuff?
about just taking a Kenalog shot? Depressing the whole thing for 6 months.
The what?
The Kenalog shot.
Well, you can.
But
I guess
wouldn't it
that's
just,
the allergy shot specific to his, what he's specifically allergic to.
right, but he was just talking about seasonal allergies.
Some people do that. Yeah. I don't know a lot about that shot, but did you guys find it? The 2 week thing?
Oh, no, I haven't.
Oh, okay. If you find it, let me know.
Okay.
These are the effects. So when you're talking to your patients that are taking antihistamines for whatever reason, make sure you guys know these. Right? And you can just think through it. Think about the anticholinergic effects. Think about the antihistamine effects, and you can kind of just think through it. Drying out, less tears, blah, blah, blah. Think of your allergies when you're out. Let's see here. We'll go through that. I've talked about that already. These are reasons why you would give antihistamines, right? Common cold, you can give antihistamines for symptoms, right? You're really dealing with symptoms when you're talking about the common cold, because you're going to let that virus run its course. Let's see here. Hey, looky here. You're going to start to see that a lot more where glaucoma is a contraindication. So why would an anticholinergic effect be a contraindication? Now remember narrow angle. Remember what we're doing when we give sympathomimetic or an anticholinergic?
The fluid in the eye, the aqueous fluid, you're increasing it more, putting pressure on the eye, which that's what glaucoma is.
Right. And so, but in particular, if you give an anticholinergic, what happens when you give an anticholinergic in the eye? Well, a little bit, but think about something else. Think about what we talked about. It helps. Huh?
Doesn't it decrease the pressure?
It's supposed to, but remember the mechanism of the eye that we were talking about to get that outflow to happen. Remember the constriction or the dilation of the pupil? So what does an anticholinergic drug do? It dilates it because it's an anticholinergic, which means it's similar to what the sympathetic nervous system would do. So if it dilates it, remember, depending on where that structure is blocked, dilating it could be bad. Constricting it could be better. So in this case, if it's narrow angle, that dilation will make it worse. Okay? So just keep that in mind when you, because a lot of these drugs now, glaucoma is going to be one of the contraindications, and it's because it will increase the pressure in the eye. Let's see here, kidney disease. Okay. We'll talk about that here in a little bit. Epi, again, see that acute asthma attack. Albuterol, so we're talking asthma there. Anaphylaxis, definitely epi, but albuterol we'll talk in a minute, because asthma is a big thing. We may not get it today. Looky here, so think about why would you not want to give an anticholinergic to somebody with BPH?
Well, because they can't urinate.
Right. What about BPH makes it so men can't?
Their prostate is enlarged, so it's harder to get the urine out, so they tend to have like UTIs.
Right, it's squeezing it because the urethra goes right through the prostate, and as it swells, and men, once you get to a certain age, it happens. This is the bottom line. Starts to squeeze down on it, right? So urine doesn't flow as well. If you give a drug like anticholinergic or an antihistamine that looks kind of like an anticholinergic, then you can have urinary retention on top of that urethra being squished by the prostate. This one here, don't give them to your kids that are less than 2. You can give them other things that work as well. You guys already know this, anticholinergic stuff. Can't see, can't pee, can't yeah, exactly. So here's your traditionals. Bro, pheneramine, see how they ended that aramine? That's one of the ways you'll know, like diphenhydramine. Those are one of the ways you know you're dealing with the first generation antihistamine. Meclizine, scopolamine's not on here, but those are your first generation. The big difference is sedation, right? And they work centrally after. Oh, let's see here. We already talked about this. The main reason we have those is because they work peripherally. You don't have sedation. Okay, we talked about that already. That. Let's see here. Just some of the things you're going to talk to your nurses about, to your patients about, right? Educate them on how to deal with the dry mouth, when to take meals, that kind of stuff. You're going to know if it's working, right? How are you going to know it's working? Yeah, you have a decrease in, yeah, you can breathe. You have a decrease in secretions, you're not blowing your nose, your eyes are drying up, more comfortable, you can function as a human, right? Sometimes allergies will knock you out. Nasal congestion, so this is similar, right? Now we're talking mostly the nose, and we're talking nasal congestion, right? One of the primary reasons why you have it, allergies, cold, goes back to that inflamed and swollen mucosa, so you can't breathe. So here's our decongestants. Okay, so we have kind of 3 different classes. Adrenergics. What side of the house are adrenergics? Huh? Yeah, sympathetic, and you see it right here when it says sympathomimetic. So we're mimicking your fight or flight, right? That causes vasoconstriction. In your nose, that's going to constrict those swollen and inflamed vessels, so that's going to help. You have your anticholinergics and corticosteroids, right? Corticosteroids are just going to work on the inflammation piece. These work really well, especially with when you're talking about nasal, like inhaled, or nasal, like Ticozone or something like that. Those work really well. And they have a few less side effects. They don't have the systemic effects necessarily that a systemic steroid would. So that's kind of nice. But these are your 3 big categories. You can have oral, you can have inhaled or topically applied. Again, nose sprays, things like that, or oral. So one of the things about inhaled adrenergic decongestants is if you take them for too long, you'll start to have rebound congestion. So that's something to remember. So what? Afrin, yeah, phenylephrine is kind of the main one in that one. But that, if you take them, they say about 5 days. If you have to take it more than 5 days, there's a high chance you're going to start getting rebound congestion. Now, if you take an oral decongestant, like Sudafed, then you won't have that same thing happen. That rebound congestion, just like it says here, that's really specific to the inhaled adrenergic type. If you use the inhaled steroid type, that's not the case. Works differently, right? It works with your immune system, kind of. It works with that inflammation piece, reduces the inflammation. So this one works on the vessels, so that's why it's a little different. Let's see here. We'll get through these. Oh, let's take a break. You guys are telling me to go.
Just leave it.
Can we sing happy birthday to Nicole?
Absolutely.